Okay, it looks like everybody's been admitted. So Dr. Seiss, go ahead and take it away.
Thanks, Amber. Dr. Bob Seiss, addiction psychiatrist with Frontier Psychiatry and community faculty at University of Washington. Welcome back to 3D Echo. Today, we're going to have a discussion regarding medication-assisted treatment for alcohol use disorder, and we have a case. We're very excited to have Jacqueline present her case here in the second half of our session. Let's go ahead with introductions from the hub sites. Amber, please introduce yourself.
Amber Rogers with Mountain Pacific Quality Health, and welcome everyone.
Mary?
I'm Mary Argonis, Mountain Pacific.
And Jessica Fry, Mountain Pacific.
Thanks, Jessica. I'm looking through the attendees. Please keep me honest here. I'm not seeing anyone else from the hub at this moment. I think this is us. Let's take it away with the rest of the group, and we can do kind of faster introductions this time around, given last week we took more time. If we could please have your name, title, where you're connecting from. Hope, please take it away.
Hi, my name is Hope Krotz. I'm the clinical director at Menida Healthcare Network.
Welcome. Jacqueline.
Hi, my name is Jacqueline Towernicki. I'm a nurse practitioner that works at Partnership Health Center in Missoula.
Welcome. Really excited for your case. Reza.
I'm Reza Gomi. I'm a neuropsychiatrist. I work at Frontier Psychiatry.
Jessica.
Hi, my name is Jessica Lauer. I'm the operations manager at Frontier Psychiatry.
It's good to have our people here in the house. Eileen.
Hi, everyone. Eileen Ford, and I am a coalition lead with Mountain Pacific Quality Health based out of Casper, Wyoming.
Excellent. Welcome. Clarissa. Looks like Clarissa's on mute. I believe that's nurse practitioner Clarissa Juarez connecting from Billings Clinic. Carrie?
Hello, I'm Carrie Foster. I'm a nurse practitioner from Roosevelt Medical Center in Culbertson.
Excellent. Welcome. Roberta.
Hello, Roberta, clinical nurse consultant, regional clinical nurse consultant for Mission Point, located in northern Michigan, UP.
Connecting from afar. We like the eastward representation. Thanks for joining us. Larissa.
Hi, y'all. Larissa Hammond. I am in Bozeman, Montana. I am a nurse practitioner. Yeah, that's what I do.
Good to see you. Welcome. Matthew.
Good to see you too.
Pat Miller, I'm the operations manager for Campbell County Behavioral Health Services at Campbell County Health in Gillette, Wyoming.
Thanks for joining us, Matthew. It looks like Leilani's connecting and the chat just disappeared. Nurse from Newcastle, Wyoming.
Audio, so
with no audio or video. Yeah. And it looks like Julie's also connecting.
Yep. And Maynette.
Great. All right. And I think we've had some other people connect. Melissa. Melissa Bates. A few other people. Let's spend a few more minutes. Sharon.
Hello, I'm Sharon Phelps. I'm with Mountain Pacific with Amber and Mary and the team, and we are pleased to be part of this and to have Frontier Psychiatry and crew leading the content for us.
Thanks, Sharon. Mark.
Aloha, Mark Marabella from Mountain Pacific in Hawaii. Thank you very much.
Beautiful photo. Makes our spring look brown out here. Tamara.
Hi, Tamara Knotts, duly licensed clinician and PCA. Thanks.
Thanks for joining us, Tamara. Stephanie.
Hi, Stephanie Cole, Prevention and Harm Reduction Programs Director at Open Aid Alliance in Montana, Missoula.
Welcome. Kaylee.
Hi, I'm Kaylee Parker, and I am the Activity and Wellness Director at Lowry Hills in Colorado.
Welcome.
Thank you.
Alyssa?
Hello, I'm Alyssa Dransfield. I'm the Social Services Director down at Lowry Hills Care and Rehabilitation. So happy to join in Colorado.
Excellent. That's some representation from down south.
Mhm.
Wonderful. Don?
Hello, my name is Don Runyon. I'm the regional ombudsman in Cheyenne, Wyoming.
Excellent. Thanks for joining us.
Absolutely.
And apologies if I haven't included everyone. I see nurse practitioner Andy McDonald is also connecting from Billings Clinic. I think she also is without a microphone. Excellent. Let's get this started with the didactic. Would someone confirm we're full screen? Amber, you seeing this well? Excellent. Quick disclosure, I'm one of the owners and co-founders of Frontier Psychiatry. We're a Montana-based virtual psychiatric practice. We will not sell our services in this echo, and the nurse planner will keep us honest. Special thanks to Mountain Pacific Quality Health for making this possible through facilitation, coordination, and instrumental support. We are currently awarding continuing nursing education. Each of these sessions is worth 1 credit hour. Please attend the entire session before claiming credit. And as we announced, we'll be offering CME starting next time on the 19th. Today, we'll talk about medication-assisted treatment for alcohol use disorder. Want to start off with a very special thanks for Dr. Andrew Saxon. He was the director of the Addiction Psychiatry Fellowship at University of Washington, where I trained. He is the editor of many substance use disorder sections in Up to Date, and is one of the primary researchers on medication-assisted treatment for alcohol use disorder. Our objectives are to firstly appreciate the evidence base for medication-assisted treatment for alcohol use disorder, discuss clinical appropriateness of different forms of MAT based on their mechanisms of action, and finally to understand how MAT benefits both patients seeking abstinence as well as those who are engaged in harm reduction programs. Let's start off with a case discussion. This is Miss CS. She's a 33-year-old lady with hepatitis C. Would everyone ensure that their mics are muted? We're getting a little bit of background noise. She thinks she contracted Hep C about a year ago. She's yet to receive treatment. She's actively injecting meth and abusing alcohol. She wishes to pursue abstinence from alcohol. Her LFTs are elevated ALT to 101, AST to 143. The systems that we can target for pharmacologic interventions when we look to do medication-assisted treatment for substance use disorders include metabolizing enzymes, dopamine reward system, the endogenous opioid system, gamma-aminobutyric acid, or GABA system, and the excitatory amino acid system, specifically the glutamate system. Today, for medication-assisted treatment for alcohol use disorder, we'll be concerned with all of these with the exception of the dopamine reward system. While some of these other pathways indirectly impact the system, we won't directly talk about targeting it. The FDA has approved disulfiram, acamprosate, and naltrexone as medication-assisted treatment for alcohol use disorder. Increasingly, we're also using gabapentin especially as an adjunct to naltrexone. It has been demonstrated to offer significant benefit in helping people cut back and ideally stop consuming alcohol. Disulfiram has a compelling history. It was first synthesized, referred to then as tetraethylthiuram disulfide in 1881. It was widely used in the production of rubber throughout the West by 1900. In 1937, at an American rubber plant, the physician E.E. Williams observed workers who were handling a compound that contained disulfiram and then consumed alcohol get horribly sick. And based on this observation, a lot of research was done to commercialize disulfiram into a medication to treat alcohol use disorder, which was widely available by the late 1940s. Disulfiram acts and offers therapeutic benefit through its deterrent effect. It interrupts alcohol metabolism, blocking aldehyde dehydrogenase, causing a buildup of acetaldehyde. This results in flushing, diaphoresis, nausea, vomiting, headache, tachycardia. In extreme cases, people can become hypotensive and sometimes even dyspneic. Contraindications to its use include cardiopulmonary comorbidities. So this sounds really compelling. What could possibly go wrong? Patients can take this. It has a strong deterrent effect. Surely they'll take it and not drink alcohol. Well, sure enough, disulfiram does not work if its administration is unsupervised. People who see a return to use of alcohol at some level preemptively decide to stop taking disulfiram, let it wash out of their systems, and then proceed to drink. Interesting enough, though, there is good evidence that goes back as far as 1976, demonstrating that supervised medication administration of disulfiram does work insofar as encouraging abstinence because of the deterrent effect. Moving on to Acamprosate. One of the things I don't like about the Zoom presentation on mute, don't hear anything from the audience. This is a mnemonic that I think many of us who are nurse practitioners, physicians can relate to. The way I kind of memorize the molecular structure of Acamprosate and also the therapeutic dose is thinking of it as a long-legged devil. So the therapeutic dose, 666 milligrams POTID. To understand how Acamprosate works, it really helps to review the process of neuroadaptation. What happens for folks who are physiologically dependent on alcohol? Here in A, we have the two opposing neurotransmitter systems, glutamate, which is excitatory, versus GABA, which causes inhibition throughout the brain. What happens when someone ingests alcohol and does not have physiological dependence on alcohol? Well, as many of us have experienced firsthand, you do see increased GABAergic tone, resulting in the subjective experience of relaxation. What happens when someone drinks alcohol on a daily basis to the point that they constantly have an excess of GABA activity? The brain, like so many of our organs, seeks to maintain relative equilibrium, and in response is going to rev up glutamate. And so through the process of neuroadaptation, you see restoration of relative equilibrium until someone goes without alcohol, in which case you have glutamate excess resulting in withdrawal from alcohol characterized by tremor, diaphoresis, in extreme cases, seizure, even alcoholic hallucinosis, delirium tremens, and in very extreme cases, death. It's hypothesized that Acamprosate acts by inhibiting the glutamate activity within the ventral tegmental area. This is part of the mesolimbic pathway, the dopamine reward pathway. By preventing the activity of glutamate, especially in people who are acutely abstinent from alcohol, Acamprosate helps restore this relative equilibrium, thereby decreasing cravings. It's important to recognize that Acamprosate has a fairly high incidence of side effects. Up to 20% of patients are going to experience diarrhea when starting Acamprosate. Rash is also somewhat significant. The medication is renally cleared, so contraindicated in renal failure. Unfortunately, in the most recent US studies, Acamprosate did not outperform placebo. From the combined study, there was a randomized intervention model of nearly 1,400 participants who either received Acamprosate with or without a cognitive behavioral intervention, naltrexone with or without the CBI, versus placebo with or without the CBI. Acamprosate showed no evidence of efficacy over placebo with or without the cognitive behavioral intervention. This is remarkable. Surprisingly, a German study did discern that there is efficacy, at least in that population, for using acamprosate. What accounts for this? It's been speculated that perhaps the way in which Americans drink alcohol and abuse it is substantially different from Germans. Maybe there's a genetic basis. We are unsure. Naltrexone. We have the molecular structure here of the parent drug, as well as that of 6-beta-naltrexol, the active metabolite we'll discuss in a moment. Naltrexone acts within the nucleus accumbens. This is a very important part of the mesolimbic pathway, the dopamine reward system. And you can see the ventral tegmental area projects dopaminergic neurons to the nucleus accumbens, so that by blocking mu opioid receptors, which is exactly what naltrexone does within the nucleus accumbens, you impact the release of dopamine. Naltrexone works to help target alcohol cravings and ultimately give people more control over their desire to drink alcohol, because alcohol causes the release of opioids within the brain, endogenous opioids. The first study that demonstrated efficacy for using oral naltrexone was published by Vopacelli and co-authors in '92. They took 70 alcoholic men and randomized them to either naltrexone, 50 milligrams PO daily versus placebo. And they saw a significant difference in the proportion of the group that received oral naltrexone that did not relapse versus those that did relapse on placebo. It's worth noting that there was a significant portion of both cohorts that did not relapse, suggesting that there was a certain baseline level of motivation in this patient cohort, and that the psychosocial intervention had a lot of therapeutic benefit. In a meta-analysis published in 2006, these findings were duplicated to scale. Naltrexone's pharmacokinetics, it's rapidly absorbed and rapidly transformed to the active metabolite 6-beta-naltrexol. Peak plasma levels of this active metabolite occur within an hour and a 10-to-1 ratio of the metabolite to parent. 6-beta-naltrexol's half-life is incredibly important because it's way longer than the parent drug, and because it's 12 hours long, we can get away with once-a-day dosing. Again, the optimal dose is 50 milligrams a day for the oral formulation. Naltrexone side effects don't occur nearly as frequently as with acamprosate insofar as the GI side effects. You do see occasional nausea, diarrhea, headache, insomnia, dizziness. There's possibility for hepatic toxicity. And of course, because naltrexone is a mu opioid receptor antagonist, it's a blocker, opioid analgesics won't work if a patient's on naltrexone, which of course is in part why we also use naltrexone to treat opioid use disorder. Pharmacokinetics of both the long-acting injectable form of naltrexone here on the left, as well as the oral formulation here on the right. Want to call your attention to here on the left, for IM naltrexone, on the top curve, it's the 380 milligram IM once a month injection gluteally versus the 190 milligram once a month injection here below. And you can see that the concentration of naltrexone here is relatively stable up until 28 days, which is why we can get away with the once a month injection, and tends to correspond to the concentration of naltrexone here with the once a day dose. We're able to do the once a day dose because there is the 6-beta-naltrexol active metabolite with a long half-life. And you can see it's quite smooth with that once a day 50 milligram dose. The evidence for using long-acting injectable naltrexone is very robust. In a 6-month-long, multi-center, randomized, double-blinded, placebo-controlled study, they included over 600 patients with alcohol use disorder and prep them prior to starting the naltrexone with a low-intensity psychosocial intervention referred to as Brenda, and randomize them to placebo, the lower dose of IM naltrexone versus the 380 milligram dose. What they saw was a significant decrease in the median number of heavy drinking days per month, remarkably between the 380 milligram IM Q-month dose versus placebo. Again, want to call your attention to the fact that across all three arms of the study, there's a huge decrease from baseline to the follow-up several months later. And we have to recognize that the psychosocial intervention, as well as the motivation of these participants, is significant and probably had the greatest yield overall. Nonetheless, naltrexone certainly helps. Similarly, you see an increased percent of patients who remained abstinent, most remarkably on the 380 milligram IM once a month dose versus placebo. Interestingly, the monthly rate of self-help attendance was significantly higher in the 380 milligram dose group at the beginning of the study versus somewhat better for the 190 milligram dose group. Placebo was the lowest. By the end of the study, everyone pretty much ended up at the same spot insofar as attendance rates. The authors of the study do explore that perhaps the fact that people are drinking less, who are on the therapeutic dose, 380 milligrams once a month, IM naltrexone, they're less impaired, more able to organize themselves and make it to group. Maybe they're drinking less and feel less ashamed, more likely to attend. It's unclear, but it is an interesting observation. The contraindications for naltrexone: acute hepatitis and hepatic failure, focusing on that as the only absolute contraindication. We can use naltrexone in cirrhosis. We do need to dose adjust. It's worth noting in this next publication we're going to briefly discuss, we do have some insight into a reasonable cutoff when we think about LFT elevation, using that as a proxy for the extent of liver disease. In this study, the exclusion criteria were patients who had LFTs elevated above 5 times the upper normal limit. People were included with LFTs that were mildly to moderately elevated and did just fine. In this study, done at the University of Washington Harborview Medical Center and another community site in Seattle, they included 31 subjects who were chronically alcoholic homeless men, not treatment seeking. It was a naturalistic sampling in that they recruited the patients from emergency departments. These patients were coming in large part due to morbidity they had sustained from drinking, falling down, etc. They were enrolled in this study, lasted 3 months, and included once a month injections of 380 milligrams IM naltrexone and engaging them in harm reduction counseling. The measures included self-reported alcohol craving, quantity, frequency, the problems they suffered, and they used biomarkers, in particular ethyl glucuronide and liver transaminases, which collectively give you a good sense of how much alcohol someone's consuming, or at least you can get a relative change. The outcomes were significant. They saw decreases in alcohol craving, decreases in both typical and peak use, frequency of use, and medical complications, lower recidivism. People were coming into the ED significantly less, and the self-reported changes were corroborated with changes in ethyl glucuronide from baseline to 3 months out. What's very compelling about this study is we see that IM naltrexone, that formulation in particular, especially when used in combination with harm reduction counseling, it can help patients even if they're continuing to drink and not overtly seeking abstinence. The harm reduction component included tips on safer drinking, like staying hydrated, tracking nutrition, and trying to maintain good PO intake, avoiding mixing drugs, in particular respiratory depressants, with alcohol, avoiding withdrawal. Gabapentin is another form of medication-assisted treatment for alcohol use disorder. Again, it is not recognized by the FDA. Yet many of us use it, and here's why. The mechanism of action is compelling in that it is a GABA analog, and it can also serve to decrease glutamate production. So again, going back to that model of neuroadaptation and what we see insofar as excess glutamate activity in alcohol withdrawal, and sustained well beyond the medical alcohol withdrawal we so often think of lasting really 3, kind of max 7 days. Increasingly, we understand that a subtle alcohol withdrawal marked by anxiety, sleep disturbance can last for up to 2 to 3 weeks since the last drink of alcohol. Gabapentin, through this action on decreasing glutamate, increasing GABA tone, helps restore equilibrium, thereby reducing cravings. This is supported by research. In particular, Barbara Mason's group in 2013 did a study over the course of 3 months, enrolling patients who were seeking abstinence from alcohol, randomized to placebo versus gabapentin, 900 milligrams total daily dose split in TID dosing, and finally gabapentin 1.8 gram a day split TID. They saw that over the course of the study, while the mean number of drinks per week decreased for all patients, it decreased the most and in a statistically significant fashion for the highest dose gabapentin arm of the study. In a study done around the same time, actually 2 years before, placebo was compared to naltrexone versus naltrexone combined with gabapentin. Focusing in on the first 6 weeks of the study when the participants received gabapentin, you see here in green compared to placebo blue and the naltrexone arm in red, you see that the combined naltrexone and gabapentin showed significantly fewer heavy drinking days, and that was sustained throughout the full 4 months of the study, even though the gabapentin was stopped at week 6. Let's go back to our case. What are we going to do for Miss CS? Naltrexone, given it by far and away, it has the greatest benefit when we consider medication-assisted treatment, is a great option for her. Again, her LFTs are mildly to moderately elevated. They're certainly not above 5 times the upper normal limit, making this well within reason insofar as the options that we can consider. And it would be very safe, given there is no history of cirrhosis. Hepatitis C itself is not a contraindication to naltrexone. So we could start the oral form. I often start 25 milligrams versus the therapeutic dose of 50. We'll start people off on the 25 milligram a day dose for the first week before increasing to 50 milligrams, so as to minimize the gastrointestinal side effects that are so common with the oral formulation. With the IM formulation, we would start with the 380 milligrams right away. It's going to be very important to engage this patient in full informed consent and make sure she has not recently used opioids, as if she's used them, especially within the last 7 days, we could precipitate withdrawal. And then combine this with gabapentin. 300 milligrams 3 times a day is a nice starting dose, especially for someone this age. And she can increase to 600 milligrams 3 times a day as tolerated, as we see this is the dose that the evidence favors. Really need to emphasize, and you'll hear this again and again across the board with a few caveats, the psychosocial interventions are going to have the greatest yield. In all the studies we just reviewed, psychosocial interventions were being delivered to everyone, including the placebo arms. We're talking about, at the very least, motivational interviewing and getting people into 12-step.
Quick question.
Yes.
With the naltrexone, do you have a preference for starting people on injectable? And what would you say to providers that are nervous about jumping into an injectable?
Yeah, I vastly prefer IM naltrexone, if for no other reason, we're guaranteeing adherence. And if we think about the lives of people who suffer from severe substance use disorders, they tend to struggle with organization. For many of us, it's hard enough to just adhere to any medications. Anytime I'm prescribed antibiotics, I have to try my hardest to be a good patient and finish the course of the prescription. And I can only imagine what it's like for somebody who is compromised in their ability to think clearly. It's oftentimes hard to continue to take meds. So, and we've seen the nice thing about IM naltrexone in particular, it will work for folks even if they're not abstaining from alcohol. Because it targets the mu opioid receptors and blocks them, it is blocking the reward we see when we drink alcohol. You're not seeing the endogenous opioids binding to those opioid receptors, ultimately less dopamine being released, and also the cravings go down as you see the entire system is downregulated. And I did plant this question. Thanks for actually carrying it through, Reza. So naltrexone, especially the IM form, rarely contraindicated, robust evidence supporting its use in treating patients, both those who pursue abstinence as well as those who don't. Gabapentin is a great adjunct, especially for the first 6 to 12 weeks. And at least based on the evidence studying US populations, Acamprosate does not work.
But it looks like Carrie Foster has a question too.
Yeah, please.
Yes, sir. So I'm thinking of a specific patient that we're dealing with, and we're in the process of kind of working with you all too here at our facility, but a younger person with AD, and we don't have a waiver at this point to use naltrexone, but we started him on gabapentin. And
I'm sorry, to clarify for the audience, if I can ask, are you calling from, is this a pre-release center?
no, this is Culbertson.
Okay, yeah, please go ahead.
Anyway, so we're seeing him, and we started him on gabapentin because that was kind of our resource. Not really a lot of drug use, but lots of alcohol use chronically for years and years. But what happens is, apparently it's a new thing, and I did not know this, but they're selling the gabapentin now. So do you have recommendations for, we kind of knew what we needed to use, but getting it into the patient, as opposed to what happened the first round was we gave him enough for a short time, took it and sold it and went and bought liquor. So I'm just looking for a little guidance or suggestions, perhaps.
Yeah, this is really compelling. You're treating, it sounds like, how old's the patient again? Oh,
He is 28.
28, so a 28-year-old gentleman with alcohol use disorder. Per your description, sounds fairly severe. You tried treating with gabapentin, he's diverting it and using the cash to buy alcohol. That is a really challenging clinical situation. Certainly gabapentin can be abused. People will use it to potentiate the opioid high. We haven't seen nearly as much abuse of gabapentin here in Montana and other regions in the mountain states, not nearly as much here as has taken place, or at least has been documented in places like West Virginia. It does happen. It'd be compelling to explore naltrexone as an option. The reason I asked if you're connecting from a pre-release center, here in Montana, some of the pre-release centers have had issues prescribing naltrexone for unclear reasons. I think for whatever reason, the Department of Corrections here in Montana may have it on a blacklist. Naltrexone, as it is a mu opioid receptor blocker, does not require a waiver to prescribe. So I would certainly favor engaging the patient in a discussion about starting naltrexone. And one of the things, of course, to be wary of is asking the patient about any recent opioid use. Sounds like he doesn't have much other substance use. And ideally also get, especially if you're going to do the IM form, get baseline LFTs and track those over the next few months. Let's definitely save time for further questions. I want to honor Jacqueline's volunteering to present an excellent case. Please take it away.
Yeah, it's This is a pretty challenging one. I liked this one because it talks about the challenges of outpatient management with alcohol use, and the challenges of inpatient and stigma, and a little bit of harm reduction thrown in there too. So my case is a 28-year-old male. I'm going to call him Nick, just so that we have a name for him. So Nick was referred to our MAT program. I work at a FQHC, so we're just an outpatient clinic, and he was referred to us because he'd never seen anybody for substance use before. His older brother is actually in jail for substance use. When we saw him, he was employed and he was living at his parents' house. His girlfriend had no idea that he was using substances. And I think he hid it very well from his parents. I feel like when you're in your early 20s and mid 20s, you're around a lot of people who are experimenting with things. You're, going to, frat parties, or you're hanging out with your friends. And so a lot of people drink and a lot of people do that, and it's very kind of normalized. So he was really not aware of how much, or in denial about how much of a problem it was for him. So when we did our intake, he told us that he started drinking alcohol in the 6th or 7th grade. He was using it intermittently and then started drinking it more consistently around his senior year of college in 2015. So the drinking eventually kind of got heavier to the point where he was drinking 2 pints, or about a half of a fifth, throughout the day, every day. He also had a pretty substantial injury to his leg, where he had some fracture. He ended up getting compartment syndrome, and he was prescribed some Oxycontin and used that pretty regularly after the compartment syndrome and all the complications that he had with his leg. And from your first talk, Robert, you could see that it doesn't take very long for someone to actually create a tolerance or dependence to it. And then, so he had been using pain medication off the street kind of intermittently. He never used injection drugs. It was always snorting or just taking the Oxycontin orally. But by the time I saw him, he was in pretty significant withdrawal. His COWS score was 24. He also has this alcoholism. He had used Suboxone a couple times off the street. So we started him with a Suboxone because of the significance of the opioid addiction. His only real significant mental health is, of course, like anxiety and depression scores, which I think are mostly related to his substance use and what he was struggling, a lot of self-shame and fear and stigma. And so he was actually really stabilized with the Suboxone. He never had any lapse of opioid use. And our CLIA in-house didn't check for alcohol use, but he would tell us he wasn't drinking. He was looking pretty good. His liver enzymes were coming significantly down. Then he got fired from his job for drinking on the job, and didn't have any income coming in, was having problems with his girlfriend. We started to notice that the alcohol was becoming more of an issue, and alcohol with Suboxone isn't safe due to the respiratory depression. Thank goodness he's young and healthy. So our options as far as treatment for his alcoholism, naltrexone unfortunately is out while he's using Suboxone. Those two don't work well together. So behavioral health is such an important piece, whether motivational interviewing, 12 steps. You can prescribe someone MAT all day long for alcohol use disorder, but without that psychosocial component, you're really not going to get a whole lot of benefit and stability. So we referred him to behavioral health, and we decided to try Acamprosate or Camprol. And I've never heard of it called a long-legged devil before, so thank you for that. The difficulty with that one is it's a 3 times a day medication. He was already being prescribed gabapentin. Gabapentin was really helpful for some of the nerve issues he had after the significant leg injuries that he had. So he had been on gabapentin pretty much chronically, and helped him a little bit with his nerves, his tremor, his anxiety, he would say. So, you know, he'd already been on that one, and we tried the Acamprosate. Fortunately, that was not very helpful. And his father had called us that he was in such severe withdrawals from alcohol. His father was monitoring his shots and giving him shots of hard liquor to keep him to the point where Nick couldn't walk anymore and was very disoriented. He was starting to have hallucinations. And at that point, it was like, I can't do a whole lot, you know, here. And I really wanted him to go to the ER. So Nick went to the ER, and I'm still to this day very astonished that they let him go, given what his lab results were. They gave him a short course of Librium, and let me pulling up his labs. His liver transaminases, his AST was 593, and his ALT was 451. So his liver enzymes were pretty high. His platelets were also very low at 91. So his liver was not doing very well for him, just being 28 years old. No hepatitis at all. So this was very concerning. They'd given him some Librium, stabilized him, and sent him on his way. So he wasn't admitted. Unfortunately, you know, the Librium made Nick very lethargic, and that scared his father, that he was zombie-like, not responding well, to the point where his father didn't want to give him the Librium anymore and didn't let him take it. Nick ended up drinking again, and he was definitely decompensating. We had been trying to get him into inpatient. There was a lot of challenges with getting his CDE completed, and just the wait list to get him inpatient, because the outpatient 12-step and medication was not doing him justice. So he was ready for inpatient. There was a lot of dragging his feet when it came to the CDE, and I urge everyone, you know, there's a lot of shame and hopelessness, and just feeling, you know, he saw his brother go through this, and he didn't want to have to go through it too. And people think of the CDE as penalizing. They think of the CDE as, you know, kind of like a nail in the coffin, when really, you know, when you talk to someone about getting a CDE, I always try to explain to them that this is the key to the door. And the more honest you are with the CDE, because I've had a lot of people get inaccurate CDEs because they are worried about the penalty or worried about being completely honest. And I tell people to be brutally honest, because the more honest you are, I'm sorry, there's a lot of feedback. The more honest you are,
this is a big barrier to him getting care at this point. And this is a really compelling case. It may be a good opportunity to summarize an identifying statement, and please keep me honest here. So we have a 28-year-old gentleman with alcohol use disorder and iatrogenic opioid use disorder, who at least was ostensibly in remission from the opioid use disorder on partial agonist. It sounds like he was doing well on Suboxone, was improving based on every objective measure you had insofar as his alcohol use disorder as well, until he became unemployed. And that really destabilized him. Per your description, particularly the fact that he was having hallucinations in alcohol withdrawal, there was concern he had complex alcohol withdrawal, meaning alcohol withdrawal with a complication, alcoholic hallucinosis. went into the ED and was determined to be a candidate for ambulatory detox with Librium. That's in the context of him having severe transaminitis. Those LFTs, if they jumped any higher, I think they'd be kind of off your screen there. So kind of putting all that in context, perhaps you're looking at the ASAM criteria for the level of care this gentleman needs. We have significant medical comorbidity, concern for liver injury. It'd even be meaningful to do a workup for cirrhosis at this point, and a history of complex alcohol withdrawal. Those are two things favoring him to go to inpatient, if not an outright medical admission, first to get him detoxed from alcohol. You mentioned that the ED prescribed Librium. One issue with Librium and many other benzodiazepines, if he in fact has cirrhosis or just a lot of liver injury, it's acute but will take some time to recover. The first step in benzodiazepine metabolism for most benzos is hepatic oxidation. That is going to be grossly impaired. And you talked about him getting really sedated on that Librium. It was probably lingering in his system way longer than it otherwise would because his liver is injured. In that case in particular, you know, if we're going to consider ambulatory detox, lorazepam, Ativan would in many ways be a better choice, as it skips that first step of hepatic metabolism and just goes straight to glucuronidation. So you don't have the oxidation phase. At this point, you have a patient who is medically sick, you're advocating for, and really seeing what you can do to engage the patient on the pathway to get the right level of care, really per your medical decision making. And I wholly support that. Where's the patient right now? Is he at home?
No, the patient is currently at the Recovery Center, Missoula. So what we were able to do is he signed a release for me to talk to his father. I called his father when Nick was in the clinic with me, and we created a plan that Nick had to agree to, which was I did agree to prescribe him a lorazepam withdrawal taper, because him continuing to drink is, as far as harm reduction, I mean, his liver is, he's 28 and his liver's failing, you know, basically. So him drinking is not an option. So even though there's the risks of mixing a benzodiazepine with him being on Suboxone, it was far less than him continuing to drink. So the agreement was it's either lorazepam or alcohol. You can't have both. And his all of his medications were going to be managed by his dad. So he had to hand over all of his meds, and his dad took that on. I mean, thank God bless him for doing what he did. And so we started him on clonidine, gabapentin. He was taking trazodone nightly. We had him on high dose thiamine 3 times a day to hopefully prevent some Wernicke's encephalopathy. And then we had him on the lorazepam taper. We did reduce his Suboxone a little bit. He was on 16 milligrams, but we reduced it by 2 milligrams twice a day because of the fact that he was on the lorazepam. He didn't suffer any kinds of opioid withdrawal symptoms, given the fact that he had the clonidine, gabapentin, and lorazepam and everything on board. And he was monitored 24 hours by his parents. I gave his dad my cell phone number, and his dad called me a couple times over the weekend because it was unfortunately, you know, when the clinic was closed. And he was able to maintain sobriety for the 3 weeks leading up to his bed date at RCM, and he is currently in RCM right now.
That's a wonderful outcome, and you really, that was a hard needle to thread through multiple complicating factors. One thing to highlight is you were sure to engage dad. And, you know, as you recognize for ambulatory detox, never mind if there are all these complicating factors, people have to have support at home to administer the benzo to keep it safe. That's a big success story.
Unfortunately, being in Montana, there's no wet shelters here. Hospitals won't keep them, so in a perfect world, his father shouldn't be put in that position, but Nick was very committed, and it all seemed to work out. So I'm excited to see him when he comes out of inpatient.
Wonderful. Is it okay, Jacqueline, if we ask you, and you let us know when would be good insofar as timing for an update in a month or so?
I'd love to give you an update. That would be great. Yeah.
Excellent. We really appreciate it. It's a wonderful case. Thank you so much. What questions or comments do folks have?
I guess I just have more of a psychosocial question about how you were able to, facilitate that trusting environment so that he allowed you to talk to his dad, because at 28, there's still maybe a little bit of that parent-child stuff.
Yeah, definitely. That does happen, and it's also a struggle because you're in a role where you are supporting the patient, but you're also supporting the caregiver and the family, because even though he's been through it with his other son, there's still that education barrier and some of the, I just wish he would get his shit together, kind of thing. And you're like, okay, all right, I understand what you're saying, but it's all out of love, a lot of it, I don't know how I have such a good rapport with my patients. I stress trust and honesty from the very beginning. I let them know that I want to be the first person that they talk, that, if stuff is going bad in your life, or if you do return to use, like I don't care. I want to be the first person that you talk to about these things. And I have a lot of heart to hearts. I'm very open and blunt with a lot of my patients. I feel that works a lot better, to have someone be very direct with them, and let them know that I care. And one of those is I'm concerned about your well-being and your safety. And I'm nervous about potentially prescribing you something that could harm you. I also am worried about not prescribing you these medications because you're harming yourself, And so how do we meet in the middle? And one of those things was getting someone else involved. I could see it's very difficult for you. I know that you're having a hard time. You don't have to do this by yourself. Who else in your life can you rely on? Because I can't be there 24 hours a day. So a lot of our patients don't have someone. This particular patient of mine was very fortunate that he did.
Thank you.
That really models a great collaborative approach in which, Jacqueline, you're acknowledging to the patient some of your fear for them, and incorporating that in the management options you're presenting. I really like that.
Other questions, comments?
Thank you so much. I really am a big fan of harm reduction. I'm excited to see more of that throughout these talks, because people are very nervous about alcohol with opiate use disorder and benzodiazepines and all of those things, but you just kind of have to, when all options suck, you pick the one that sucks less.
Jacqueline, in your work in opioid use disorder, do you have access to quantitative drug screens? In particular, can you pull ethyl glucuronide?
Yes, we have to send those out, and it takes, I don't know, probably about 5 days for us to get them back. So yeah, we started doing that a little bit more frequently, but they are a little more costly and they are sent out, but we do that, yes.
And that's really compelling. As you identify, harm reduction can really inform how you engage with patients. And sometimes you're not demanding abstinence from alcohol, but hey, you can take a win if they're ethyl glucuronides in the 3000s, if they get it down below 2000. Acknowledge that as a relative win. Very compelling case. Thanks so much. So I do
Any
see a
other
question
questions for Dr.
about
Seiss?
covering drug screens. It varies widely by insurance. Remarkably, Medicaid, at least here in the state of Montana, does reimburse for quantitative as well as qualitative urine drug screens, which is invaluable if we're prescribing something like buprenorphine that is a partial respiratory depressant, and we're worried about other respiratory depressants, including alcohol. The quantitative urine drug screen can give us actionable data that is way more than just plus minus presence or lack of a substance. But certainly some of the commercial insurance plans don't offer great coverage for urine drug screens, and that can be an issue.
Any other questions before we leave? We got 3 minutes. I've put in a couple of times about requesting a case. So feel free to reach out to me individually. And then also on our website, there's a really quick case review form. And it's really not scary, is it, Jacqueline? Okay, well, we got 3 minutes left. Time for another question if you all have one, or just another tidbit of a jewel of wisdom. There is some comments about dosing for vitamin B.
Oh, yes. So I did get a vitamin B level, blood level. I drew it just to make sure what his blood levels were. If they're pretty deficient, you might want to go to an IM. You might want to move to an injectable form. The reason why a lot of people, and please, Robert, pick somebody if I overspeak or don't speak the right thing, that a lot of people don't absorb, a lot of people with alcohol use disorder have a difficult time absorbing and metabolizing, like utilizing vitamin B. And so they become vitamin B deficient, and that puts them at risk for different types of anemia or encephalopathy. So if their vitamin B levels are really low, you might want to go with IM injections. Otherwise, I would have to do, I recommend 1,000 milligrams 3 times a day, because even if they're not drinking actively that day, their absorption rate is still slow. So multi-day dosing is preferred.
Yeah, we definitely echo, Jacqueline, the need in instances in which someone is acutely encephalopathic, you have a clear indication of malnutrition, and you're worried about Wernicke's encephalopathy. You got to go really high in the thiamine, and it better be at the very least IM, if not IV. To your point, British Medical Journal did a great publication, and oftentimes what we use on inpatient in managing alcohol withdrawal is their regimen from the NHS, which is 500 milligrams IM or IV, depending on what access you have, 3 times a day for the first few days before you step down to 250 milligrams. For the oral dose, in general, I don't exceed a few hundred milligrams a day. And the teaching I came across is, simply put, if you're worried enough for Wernicke's, that patient should be getting it as injection. Of course, as you have identified several times, Jacqueline, sometimes we just don't have the option because patient won't present for hospitalization or they're not admitted. So, basically getting any vitamin B1 on board, thiamine to the max, is a relative win.
So are we doing 100 milligrams 3 times a day? You think that's still too much?
I think that's wonderful. That's what I would do if we're doing oral. Okay. I do think because the actual absorption you're going to get from the gut is limited. Anything more than that is probably just ending up in the urine. But I mean, I think you're not going to give them toxicity. If anything, you're worried about the reverse.
Well, thank you everyone for attending. This was great and heartwarming as well.